Good afternoon, and welcome to today's program titled The Future is Hybrid, Redesigning the Healthcare Workforce. My name is Jay Asser. I'm the CEO editor for HealthLeaders and your moderator for today's webinar. Today's program is sponsored by Collette Health. Thank you to our sponsor and to you and our audience for giving us your time and attention. Please note that an on-demand version of this program will be available approximately one day after the completion of the event. It can be accessed using the same login link that you used for the live program. Before we get started, I have a few housekeeping details to go over. First, to ensure that you can see all the content for the event, please maximize your event window and be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Second, you will find a resource list for today's webinar in the upper right of your screen. Here, we have listed the webinar slide deck and additional materials for you to interact with. Third, at the bottom of your console are multiple widgets you can use. To submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. Should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. Finally, it's my pleasure to introduce our panelists for today's program. We have Dr. Christine Gall, Chief Nursing Officer from Collette Health, and Amber Price, Senior Vice President and Chief Nursing Officer from Sentara Health. Thank you both for joining us today to discuss this very important topic. Before we jump into things, could you please tell us a little bit more about yourself and your organization? Amber, I'll start with you.
Sure. Yeah, I am the Enterprise Chief Nursing Officer for Sentara Health. We are an integrated delivery network with health plans and facilities in Virginia, North Carolina, and Florida, about 34,000 employees. My background, I was a nurse, then a certified nurse midwife, delivered over 1,000 babies, eventually went administrative, became a hospital CEO, and then just moved to corporate as Chief Nurse Executive.
Great. And Christine, can we hear a little bit more about you and Collette Health?
Sure, Jay. I am Christine Gall. I'm the Chief Nursing Officer at Collette Health. Collette Health provides virtual care hardware software solutions for organizations that are looking to expand their hybrid workforce model. My role within that organization is to go shoulder to shoulder with my nurse leader colleagues to help with the workflow redesign, ensuring that we are identifying the right measurements to evaluate success and to ensure that we are appropriately standing up the virtual care models to address the pain points that they're trying to solve. I live here in Wisconsin. This is my absolute favorite time of year. And clinically, I started out my nursing career in pediatrics, have had roles in pretty much every level of operations within health systems, have also done benchmarking, and have done work in the public health domain as well. Happy to be here.
Happy to have you. Happy to have both of you. There's a lot of great expertise on this panel. Thank you again for both of you for joining us to discuss a topic that has become prevalent in recent years, especially since the start of the pandemic. Delivering care is no longer confined to one fixed location, as advancements in workforce design and technology are creating greater flexibility. But hospital leaders are still working through how to balance that flexibility with care quality to make hybrid models as effective and sustainable as possible. Before we get into specific strategies and approaches to achieve that, I want to start by asking both of you, how do you define a hybrid workforce model in healthcare today, and what distinguishes it from traditional staffing models? Christine, can you kick us off on this?
Sure. You know, we are really in a unique time. We knew that we were going to have challenges with the aging of our population. We knew that staffing was going to be a challenge, and we've been working with our schools of nursing to really beef up the folks that are entering the profession. And then the pandemic hit, and that added just another layer of complexity that really has gotten us to this point today. When I think about hybrid workforce models, for me, there are a couple of components. The first is that we're looking for ways to better match and leverage our existing human resources to the needs of our patients, the operations of our organizations. And to do that, we need to really reimagine the way we're looking at care altogether. I said very early on, when I saw how the pandemic was impacting our healthcare system overall, that we would never go back to pre-2020 when it came to healthcare delivery, and that's definitely coming true. I think flexibility is one piece that defines a hybrid work model. The other is combining resources that physically are not co-located. So that virtual care model has become front and center, a very important part of hybrid work models. And then aligning resources in a way that best matches how patients are accessing care, from pre-admission to admission, to transfers within the health system, to post-discharge back into the community. So that means that there's greater opportunity for flexibility, different styles of roles, new roles that are creating, and I think we'll get into that through our discussion. It's a reimagined way to deliver healthcare and to support patient care. So that would be where I would start with a hybrid workforce definition.
Great. And Amber, from your perspective, how do you define this idea of a hybrid workforce model?
Well, it's an interesting question, because I would say that a year ago, I never talked about anything hybrid when it came to care model. And now I probably use that word several times a day, because as you're brainstorming through where you're going to go, the reality is that often you can't do everything at once, particularly in a very large system with many different silos that need to get broken down in order to truly function as one large IDN. But for us, there are probably three ways that we're using the term hybrid. The first one is through centralized workforces for things like remote patient monitoring, where we have 2 large centers that serve our entire system that are completely virtual. That has already taken place. The second one is moving virtual nursing into the actual unit, into the nursing unit itself, and having nurses work part of their shift or part of their week is virtual, part of their week is actually doing patient care. And then the third way is when we're trying to move something to a virtual platform, but we're lacking some of the things that we need for that, like a monitor in every patient room, or whatever that barrier currently is, where we keep a few people still in traditional care and move the other part of that workforce onto a virtual platform. So hybrid tends to be the solution, particularly as you're implementing something, and in future, that could then be wholly virtual. So we use it in those 3 different ways.
Great. Yeah, I think that's a great way to kind of set the table of what we're talking about today in this discussion. And Amber, you alluded to some of those challenges organizations are encountering when transitioning to these hybrid models. What are you seeing as the most common ones, and how are those maybe evolving over time right now?
Yeah, I think, at its most basic, it's just understanding the equipment and how you fit it in your room. Coming up with the capital to do that, particularly in a large organization. Because the thing about going into a virtual care model is that you can't just do it in tiny little pockets, right? To make the investment, this is something that you should do standardized across your entire organization. So just working through that initially and creating the business case is an interesting discussion as you're, introducing that to your own senior business leaders. So the other part about it is to help your teams understand how to work within it. How to restructure the workflow day to day, and having people understand that this is designed to give time back to the person who's caring for the patient. And then the third one is that the community is still very leery for anything that's technology or that has AI tied to it in any way. And so explaining this to the patients and how this works into their care model initially was challenging, although I see that the community is pretty literate about this, and we're no longer getting as many questions as we did maybe a year ago.
Yeah, and Christine, are you seeing some of these same challenges, or are there any different ones that you're encountering?
Yeah, I echo everything that Amber just said. To highlight the technology piece, I think it's important. One of the challenges I think is what is the right size of technology right now? You want to start at the right level so that you're balancing your the finances needed to support that, along with the pain points that you need to address. So I've seen everything when I travel and I work with my colleagues, everything from wanting to go the full smart room concept initially, before you even have had a real experience in launching a virtual care model, and then the other side starting out really simply with maybe an iPad and some of the challenges there. So I think the technology piece is something to really think about, and what your short and near-term plan is, so that you can really line up your needs as well as the finances needed to support. When it comes to workflows, I absolutely agree with what Amber said. Involving the people who are actually being charged with changing the way they do their work from moment one in this process is so critical. And the only other thing I can add that I don't know has been mentioned yet is the whole concept of adoption. When I think about throughout my career, things that were great on paper, but then in implementation failed to meet the expectations, I think that one of the biggest blockers in those situations has been a failure to appreciate that humans need to understand the whys before the hows. And what is this? Why are we making this change? What is it going to do for me? What is it going to do for my patients? And I think that that's really critical. So a lot of the time that I am spending in my role is helping with change management and adoption. So I think that addressing those challenges up front and getting your champions aligned one conversation at a time is really critical.
And just curious, is there a specific example that either of you have maybe dealt with at your respective organizations with any of these challenges mentioned that proved to be, more difficult than maybe you expected? And how did you kind of address that? Is there any example that either of you can share that comes to mind?
Yeah, I will say for us, when we made our business plan, we immediately identified some of the things that we thought were going to improve. For example, throughput from our EDs into patient rooms, because now admissions can be done by a virtual nurse rather than having to wait for a nurse to take report and get the patient in the room. But when we started talking about what those actual KPI are, there was some, confusion across the board going back and forth. How do we know that this implementation is the one thing that changed our throughput? And how do you prove that? So we actually landed on something that was a pure nursing KPI initially, and that was nurse turnover, because this is supposed to be helpful, it's supposed to give support to our new grads as well. So we, for our initial implementation, stuck to nursing turnover as the KPI, just to keep it clean.
Great. And Christine, I don't know if there's any example that came to mind for you.
Yeah, when you asked the question, what immediately came to mind for me was the fact that when you are asking people to work with a virtual colleagues for the first time, that's a new skill set. And I think we often overlook that, okay, we're just going to divide and conquer this labor, but there truly is things that people need to learn in how you communicate with members of your team that aren't physically right next to you. And a related point to that I see time and time again when I'm supporting implementations is, how does that communication flow? What you don't want to have happen is have unintended consequences that create new problems that didn't exist before you implemented. And one of the areas that I think is so essential to think about is, how are you going to know if you have two people that are managing a single patient, how do you know who's done what and when they're done with that? Spending the time and making sure that your technology, your EHR, your communication systems are all integrated and aligned in a way that it's forcing information out without both teams having to do something manually to make it happen, so that you can look to see, oh, this patient's ready for me, this is the person next in the queue. Those are really important components that I think often get overlooked until you implement and you learn very early on that something didn't go as expected.
Great. Yeah, Amber, you spoke about metrics, and Christine, you spoke about communication, both two areas that I think we'll get into much more as we go into the conversation. But next, I want to focus a little bit on culture, because of course, a hybrid workforce model cannot really be successful or sustainable if the right culture is not in place at your organization. So what are some of these organizational or cultural shifts that are required right now to really integrate that in-person care team? Christine, could you kick us off on this?
A few years back, I spent a lot of time doing culture work at a large health system. And first of all, I think one of the biggest imperatives is that you have an executive champion who is fully engaged, visible, and is willing to have those conversations in the hallways, in the meeting rooms, with their staff, with the patients. Because when you're dealing with something that truly is a major change that is going to impact both the way you deliver care and the true culture of the organization, it's so very important to have that figurehead. The next component that I think is really important is, I'm going to go back again to communication. We need to make sure that we are sharing information about the connecting staff and patients with the why, but then also doing as much listening as speaking, hearing back what the concerns are, what the issues are, and then addressing them one by one, conversation by conversation. That flow of information needs to be bidirectional. It needs to be going both ways, so that the staff who are being asked to change the way they do their work are feeling heard, that they feel that they have the ability to influence how those workflows are determined, and that the impact is that the goals of all of this are not just a bottom line goal, but it's truly to give them more time so that they can do their job, have greater resources, and the ability to provide the best care for their patients. So I think those are two top areas that when you're talking about culture and big changes to culture that are really key.
Great. And Amber, what are some of these cultural shifts that you're seeing on your end?
Yeah, I fully echo the buy-in of the executive leaders from the very beginning. And we had to do that. We had to make sure that we had the right team with the right enthusiasm. We have a vice president of clinical operations, and then we use our nursing informatics teams in the hospital itself, and then the vice president for nursing informatics. They're heavy drivers of this because they're also workflow experts, so we work with them. But I think there's a bit of a unique challenge if you are doing this within a health system with more than 2 or 3 hospitals. So our 12 hospitals are geographically not necessarily near each other. A few are, but the others are kind of remote from one another. And what happens over time is that everyone develops their own culture, right? To the point that some hospitals have care models that differ a bit from other hospitals, or if we acquired that hospital where things stayed in place that were unique to that facility. But once you start centralizing and you serve an entire system through a centralized platform, so that, somebody who's sitting in a facility in Richmond is advising somebody in Charlottesville, Virginia, or giving virtual support in Virginia, you need to be structured the same way. And so we had to work on standardization of all 12 of our hospitals so that we had similar models and similar ways of doing things and similar ways to document before we could really standardize this new thing. And that is an ongoing effort. And that is, paramount, because over time, more and more things will become centralized and move out of the facility. And it needs to work every time in every facility that we support. So that for us was a challenge. And I know that we'll talk about this more, but how we actually began was with our frontline staff, having conversations with them, using our shared governance structure. We realized that every time we make a change, we can't go, to 14,000 nurses and ask them what they think. But what we can do is work together to set a set of core principles around this change management. And so we worked with our nursing teams, began by having our nurses identify who actually walks into the room today. I felt really good about myself. I could think of 29 different providers or people that walked into a patient room. But once we asked our nurses, we found more than 200 different people that could walk into a patient room, from a dietary tech to a pharmacy tech to, the person with the therapy dog. We listed them all. And when we had a realistic look at that and said, that's way too many people, this isn't a healing environment, we need to prioritize that. Let's talk about how we create a healing environment while preserving those core principles that we value as Sentara nurses, right? We wanted to maintain or improve experience. We want to maintain or improve safety. If we do this, it has to improve nurse well-being. So we made a long list of those core principles, and that's what we all agreed on across all of our different hospitals who are all working on standardization, and that's the core principle set that we follow. We then also created a list of hard stops, things that we would agree on we were not going to do. And one of those was not to change our nursing ratios, our nurse to patient ratio, and to keep that the same. And then we had several others, right? Limitations of the platform, or if it didn't meet the needs of the organization. And so once we built that core set of principles and we could all agree on it, it was easier to move through change and have everyone feel confident that we were doing that in the right way, as long as we were adhering to the core principles that we set together. So that's the work we did around culture.
Great.
Jay, if I could underscore, I think Amber just beautifully painted the picture of the connection to why. I think from my travels, some of the biggest fears that staff have is you're doing this to cut staffing. You're doing this to just save money by reducing nurses and increasing patient ratios. And when you are able to do exactly what she just described and talk about all of the downstream impacts, when you talk about saving $60,000 to $70,000 for every nurse that decides not to leave, the bottom line impacts will show themselves. And helping, bring that conversation along, I think is so very powerful. So I really appreciate and value, Amber, the way you've approached that and really empowering your staff to be part of the conversation and in that entire journey. That's great.
Yeah, I mean, you bring up a really, important point here, and that is that this is so new that there's not really a best practice that has been identified in the nation, right? There's a tremendous amount of interest. So when we were tasked with doing something completely new, we went to what we know is the right thing to do, and that is to do it together. And so now when we have a suggestion, we don't come up with the idea ourselves, we take it straight to our nurses. I wanted to embed a virtual nurse on one of our busiest med-surg units that has a hard time keeping staffed, and said, what would you do with a virtual nurse if that nurse were on your unit? And the nurses came back to us with some phenomenal ideas. The other work that we did is to try to understand the healing environment, because if we have an opportunity to create a better healing environment for our patients, then I know that it's easier for nurses to adapt to a change, because nurses at their core just want to provide great patient care and want to have time to do that. That's at the core what every nurse wants to do. And before you do that, you have to understand what your healing environment is like. And when you zoom out and look at what a normal patient day is like in any facility in the United States, we know that on average, there are 85 times that someone opens the door in a 15-hour time frame. And of those 85 people, when you start counting how many times we're touching a surface, you're at 256. And so, we all know that that's too much. That is not a healing environment. And so we have framed the future of healthcare using AI and technology as an invisible care environment for our patients. So it's a healing environment, an invisible care environment, and then we all have to agree on what needs to still stay at the bedside and what we all feel comfortable can not happen in the room. You have to do a little bit deeper dive. You have to think through what each of those entries are. How much of those are administrative, how much of those require an RN skill set that you can't remove or take away. And then you have to challenge yourself, right? People come with biases of, no, we could never put that virtual. And then, 3 weeks later, when you start to think about it, you realize you can absolutely put that virtual. And so these are the conversations that you need to have with the people in the room who are the experts on the experience of the patient, and take your time getting all of that feedback before you start making those early change decisions.
No, I think that everything both of you said is extremely important, and I think it's a great lead into the next thing I want to ask, which is how can organizations right now scale virtual nursing without overwhelming bedside staff and keeping those frontline workers, keeping the focus on them and what they need, what they require, what will work for them, what won't work for them. How can organizations, hospitals go about that right now? Christine, can you start us off?
Well, I think the first thing to know is failing, meaning something doesn't go as anticipated, isn't a failure. It just means that you learned how something isn't going to work. And so when I think about how I help support the executive leaders that I work with, I first start by saying this, like any other change management process, is going to be iterative and it's going to require rapid cycle improvement. So you have to wrap your resources around that and recognize very quickly if something is working, you're going to adopt it, and that's where you can start scaling. If it's working partially, but there's still some issues, you might have to adapt it and continue in the testing in the pilot phase. And if it's not working, fail quickly, abandon it, learn from it, make sure that communicates out so that everybody understands the why. Because in my experience, when people are not given the benefit of complete information about a topic, they'll fill in the gaps with their own version of the story. So I think, again, that communication, sharing information, celebrating together, and also addressing, what isn't going well, and very quickly earning the trust and respect of the staff that when things don't go well, that is when people are going to circle the wagons and figure it out, learn from it, and move forward, which is what nurses do every day. I think that that's really important. The other thing I wanted to tag off of something that Amber said earlier, and that is you can have 2 med-surg units or 5 med-surg units with similar populations, and the workflows will be completely different. That's inherent, and that's part of the problem or challenge, I guess, that we have is you can't simply take a workflow off the shelf and say, this is the workflow that works, because there's so many dynamics in play. So when you're looking at scaling, it's so very important to have that common vision that Amber mentioned, but also then be able to look at the workflows. There are going to be, in every single workflow that I have worked with teams on, there are tasks, activities that used to be important. There used to be a reason, and it's no longer necessary, but somebody didn't recognize it, and people have been doing this very same task. And one of the opportunities I think that is really exciting about these overhauls of workflows is being able to identify and surface things that are not adding value to the entire process. And as you scale with that common vision in place, this is where you're looking at those opportunities to standardize and to learn from each pilot and each onboarding. So as you scale, you only expand your expertise and your knowledge base.
Amber, can you add on to what Christine is saying there?
Yeah, I mean, probably going in a bit of a different direction here. Just from feedback and having talked to other CNOs across the nation, one of the barriers that we fortunately don't have is getting the IT to align to what you're trying to do. For companies that outsource their IT, there's a whole nother legal barrier that gets created. You now have to go through another person's legal and compliance and risk system, in order to deliver what you need. So having your own IT infrastructure and your own legal infrastructure in your organization who already know how to drive change together is absolutely key. Otherwise, you're going to get tangled up in other people's cultures and philosophies and risk management issues. We decided to go as quickly as possible. So we actually launched all 12 of our hospitals in under 8 months. And we went one hospital at a time. We learned from each one, as we went along, because of course you have to, keep 12 rooms open on the day you're installing the technology. Well, imagine what that does to the throughput in your emergency department. So we had to learn, how to do that without blocking the normal operations of each hospital that we were implementing this in. We also stuck to, in our first 8 months, the same thing, that we promised from the beginning. Our virtual nurses will do admissions, our virtual nurses will do discharges, and our virtual nurses will do education. And that's it. We're not changing that. We're not doing anything different. So each launch was exactly the same. The services that those nurses provided was exactly the same in every hospital. And of course, the virtual nurses themselves didn't change. So they had already been working by the time you're launching your 6th hospital, and they've learned from each launch. Where I saw some bumps and hiccups was in hospitals that had a discharge nurse already. So hospitals that were working with a discharge nurse, where the nurses kind of handed off that entire process to one person, nurses had to reintegrate into the discharge process because the virtual nurse can do the verbal component and make sure the patients understand their medication and everything is good. But now the nurse still has to take out the IV and do all those things and help that patient get to their next level of care. So we had to reintroduce a task that had actually been removed from the bedside nurse. And as I'm kind of scanning the questions that are coming up, I'm seeing, kind of a theme around communication and, how we're managing that and what the role of the nurse is going to become. We made it clear from the beginning in those core principles that this was meant to help reduce errors, to create a safer environment and a better healing environment while creating a sustainable nursing model for the future. We all know that the way nursing is structured today is extremely overwhelming at the bedside. It is not sustainable. We know that we have a lot of nurses out there who just can't come back and do a 12-hour shift in a unit because of the way we have allowed nursing to develop at the bedside. And we have to acknowledge that, and we have to frankly speak to that. And you have to simultaneously do all those other things that get in the way of a great workflow for your nurses. And if you keep patient safety and the healing environment at the forefront, then everybody has that buy-in, and it shouldn't feel like being overwhelmed. It should feel like we took something off your plate. And so that is how we're approaching it. Now, where this will take us in the future, once everyone's used to partnering with a virtual nurse, that's going to be a different kind of care delivery. But we're going to get there together once we're all used to integrating this into our day-to-day operations.
Yeah, I just want to take a moment. We're halfway through our discussion today. We have about half an hour left. And I just want to, again, invite audience members to send in questions through the Q&A widget, which our panelists will answer at the end of the hour, at the end of the discussion. And so the next thing, I know we've kind of touched on this a little bit, but what are some of the technologies that you're finding are having the most success at solving some of these challenges in terms of communication and collaboration within your hybrid teams right now? Amber, could you start us off here?
Yeah, we kept it simple. We only have our virtual nursing platform. What we did do is integrate some of the other platforms we already had onto that same platform. For example, we had a different remote patient monitoring system that required rolling cameras into the room. And we removed those rolling cameras and moved that remote patient monitoring onto the same platform. So we consolidated into one platform. And what we learned along the way, and this is an important takeaway, is that when you use mobile carts for anything, even if it's for virtual nursing, it's much less likely to be adapted and utilized by your teams. Nobody wants to stop, run, go find a cart, troubleshoot it, roll it in a room. If it's not hardwired in the room, we see much less utilization. So we've made a commitment to make sure that we're hardwired in every single patient room. And we're not quite there yet, which is why we still have to be hybrid in some of our facilities as we develop these new care models. We focused on our med-surg units, our intermediate care units, and our heart hospital, and our ICUs for this implementation. So it's not in our ERs yet. It's not in those places other than in those, full-time inpatient care med-surg type units. And we're sticking to that until we need to expand it. So for us, that one platform and consolidating what we already had onto it is how we began.
And Christine, what are some of the technologies that are maybe having some success at your organization?
I think it's making sure that you're matching the features and functionality of the platform that you choose with how you're going to practice virtually. That's important. Integration is paramount. Absolutely. If you are removing barriers in one aspect of the workflow, but creating new issues or new tasks on the other side that are administrative and taking away from that nurse's ability to care for patients, you haven't really achieved the ultimate outcome. So making sure that there is that match. The other thing that I think is important is making sure that the organization that you are going to work with, that is going to be your technology vendor, has a vision for their future. Their product roadmap is aligned with the pace at which you are going to expand your program as well. So really looking at not only what the features are now, looking at how they are planning for their future growth and future expansion of their services, and making sure that there is a match. This is probably one of the biggest investments that an organization will make during this time. So it's important that it's done well and done right, and that there is that alignment. So I appreciate everything Amber said as well. It's really important that you're addressing all of those points simultaneously.
I'll add on and also kind of to answer the questions that's popping up, that collaboration is very predictable. So our nurses know what an admission looks like from a virtual nurse. Our nurses know what a discharge looks like from a virtual nurse. We can script those encounters. And that actually allows you to make sure that you're not missing something, right? These nurses aren't being pulled away to an emergency. We know that we're going to hit all the points we need to hit during admission and discharge. So there's also a bit of a boost that we've seen in patient experience on those discharge questions, for example. People feel like we've thoroughly explained their medication, which, is one of those things that we were kind of stuck on in our patient experience. But there's not something occurring in big communication between the virtual nurses and the patient that would be, pertinent for our nurses, about care delivery, because it's at the very end of care delivery as somebody is going home. Now, what we have seen is that, a virtual nurse might be doing a discharge, and as they're asking the patient questions, realize that there may still be, a medical need and this patient shouldn't go home. They contact the nurse immediately, and then they come in and reassess the patient. So it's not that communication isn't happening, and the nurse is the one who prompts that virtual nurse. So you're actually putting that in the EMR. Hey, it's time for a virtual nurse to come do the admission. Please pop in. That message is sent to the virtual team, and whoever's next in the queue to do that will pop up in the patient's room and do that. So this isn't happening outside of the nurse on the floor. The nurse on the floor is driving that and knows exactly what's going to happen during a discharge or admission session.
And we're talking a lot about workforce-specific solutions here, but of course, these hybrid models are also meant to enhance or supplement the delivery of care at the end of the day, right? So how can leaders really ensure that that these hybrid models are improving care and improving the continuity of care? Christine, can you give us some insight on this?
Sure. Well, I think one of the exciting opportunities that have presented because of hybrid work models is being able to extend the careers of our seasoned nurses who would have otherwise left the bedside. And I think that that's so very important because their expertise, thinking about the nurses who grew up in an era of nursing before the electronic health record, and the way you thought about care was very different than it's organized now. It's really a skill set that needs to be passed on in certain ways to the lower tenured nurses who are just arriving on the professional scene now. So I'm really excited about the ability to leverage the expertise of nurses virtually, where they can actually provide more. They're not now as challenged by the physicality of the work, but they can really use their memory and their knowledge and expertise to its fullest potential. I think that's really very important. Also, there are challenges, though, when we're talking about the fact that really every department in the hospital somehow goes through the bedside nurse. And the bedside nurse has some level of impact on virtually every department in the hospital. There are unforeseen challenges that can happen downstream when you're changing processes without really following it through to how that can reach out. So I think that when we look at that iterative process, recognizing that you might be impacting the area of focus that you were focused on when you made that change to the workflow, but there might be other things that happen that you didn't intend, and being open to understanding that, and then being able to, again, bring your teams together for that rapid cycle improvement to figure out how to address it. Those times can be really turbulent. And, the staff who are being asked to be so flexible and agile to say, okay, we're doing it this way today, and we're going to iterate, and we're going to build upon this. It's in some ways that can feel like it leaves some staff feeling like they're not in control of the process that they're being asked to support. So it's really important that as leaders, as the champions, you're looking out for those areas where turbulence might be being felt, and being able to make sure that you are stabilizing when you need to stabilize. So I think that those are areas that I think are really important. The other thing that I'm very conscientious of, and Amber said this before, I would venture a guess that most people, if asked to do the work of a bedside nurse, would not be able to manage it. And add on top of that, when I entered nursing, the average tenure of the pediatric unit that I was on in a pediatric hospital was 15 years. Now the average tenure is 2 to 3 years on the average unit. So, and because care has become more complex and the workflows have become untenable, it is a very challenging job. And as such, I've seen statistics between 40 and 50% of nurses who graduate from nursing school are actually exiting the profession within 2 years. That is something that is signaling to all the leaders that we have a problem and we need to resolve it yesterday.
And Amber, where are you seeing those opportunities to really enhance patient care?
Well, we've asked our patients and we've asked our nurses this question. And when you do that, you're going to get really great answers, right? One of the ways we're doing that is by implementing AI, which is a completely different discussion than virtual care. Virtual care is a Sentara employed nurse who knows who we are, who's sitting in a centralized location with a manager, right? It's like having any nurse in Sentara. We know who those people are, and we know the care they deliver, and we monitor that care. So that's not the part we're concerned about, impacting our quality. What we were concerned about is the impact on how the patient experiences their care. So we had to actually build a data set so that when we report out our patient experience, we can pull out those patients who had a virtual encounter. So we could track that. So we're not just assuming things aren't going well or are getting better. We can actually prove it. We can pull every score by what experience the patient had virtually or not. So we can actually track it by nursing bundles, and we can say this got better or this didn't change. And so we now have early data, about 6 months worth of data. And we can, confidently say that this is improving our patient experience marginally, but it is improving the patient experience. And that then is something you bring back to your nursing teams. They need to know that, because to what Christine so beautifully said earlier, if you don't communicate it, people make up their own narrative in their head about it. So we need to have hard data, you need to build it, and you need to integrate it. The AI side is much more influential on the quality component. For example, as we're moving forward next year, and we'll probably have this in place in January, hand hygiene will be monitored by AI in the room. AI knows when the patient's movements start to change and alerts us that the patient may be trying to get out of bed. So that could help with our fall prevention. AI can tell us when a patient has been turned. So as we're looking at skin integrity, AI can track that, and it can tell us if that has occurred or if it's overdue. And so these are things that are, for our nurses, they are reminders. For us, they're a way to track what our opportunities are. And so we will be then developing data sets around that, because you can pull all of that data back out of your system and start tracking to see what's actually happening and occurring in the patient room and where people need more help. We've all added team members over the years. We've added mobility techs, and we've added, different kind of nursing supports, from sitters to PCTs to other things. And so AI is going to help us understand what the optimal workflow needs to look like. And I do think that it will result in different types of positions in the future, right? To different types of support than we've put in place today, because everything we put in place today was in response to giving time back to nurses. And now virtual care and AI are going to give that time back to nurses. And so that is going to help us understand how we need to develop the care model of the future. For us, the big priority is year one retention of RNs. We know that a lot of our first year nurses leave in the first 6 months completely overwhelmed, not understanding what that workload was going to be. And we have different generations now that are saying, I don't need to work this way. This isn't how I want to spend my days. Or are concerned that they will harm a patient because they get overwhelmed or busy if somebody calls out. I always say the virtual nurse doesn't call out. You can rely on that model on your floor. It's a consistent in your day, and it makes it a bit easier to plan around what your care model needs to look like. Now, Jamie Carroll, our VP of Clinical Operations, says virtual nurses do call out. And I said, yes, they do for you. But for the nurse on the floor, there is a virtual nurse that's going to come. What we want to ensure is that we're also supporting those first year nurses. So we're launching a nurse assist function. If there's a nurse in the room who wants a second set of eyes, right? These cameras are so advanced, they can zoom in on a nostril hair, right? Can you help me determine if this site is infiltrated? Hey, what's your opinion? Hey, are my lines done okay? You can now immediately call somebody up on that screen. And what's really exciting about that, if you go back to kind of, our medical education, is that Hawthorne effect, right? If you know that somebody's watching, you sometimes behave a little bit differently. So when we have contentious situations in the room, sometimes knowing that there's somebody watching virtually, we've already seen in remote patient monitoring that it makes a difference in how we communicate with our patients. That's a good thing. But for new nurses, once you move on from your preceptor, it's really embarrassing to have to go back out in that hallway and go find your preceptor for something that you really should know. But nobody knows that you called up a nurse assist and asked the question. We make it way easier to be comfortable to say, I need a little bit of help. So that level of support for new nurses and existing nurses, we think will reduce a lot of hunting and gathering, which is where 25% of a nurse's time goes, and makes it easier to give support to folks that need it the most.
Great. This discussion has been great. A lot of great detail and depth from both of you. I want to make sure that we have a little bit of time to get to the Q&A section. We have a few more questions left in our discussion that we can perhaps go back to if we have some time, but I want to make sure, again, that the audience has an opportunity to ask the two of you questions. So just as a reminder, again, to submit a question, click on the Q&A widget at the bottom of your console player. It may be open already and appear on the left side of your screen. Please note that your questions will remain anonymous and will not be viewed by any other audience members. So first, we have a question asking, and I know we talked a little bit about this already, but how do you ensure that communication stays fluid from what is being discussed by virtual models and also the in-person team? Christine, can you start us off here?
I think that this is something that by design you have to really think about intentionally how that communication is going to occur. So obviously the first part is the technology. Do you have the technology that's going to allow that virtual nurse to connect directly with the bedside nurse when needed and vice versa? But then on top of that, there has to be a layer of when should this occur and when shouldn't it occur. That there has to be kind of I guess rules of the game for you will absolutely alert the bedside nurse if these 5 things happen. Vice versa, if something happens that the bedside nurse becomes aware of that is going to impact how the virtual nurse does his or her job, those have to be kind of rules of play and rules of conduct that are identified ahead of time. So it's really creating a way of thinking about how you communicate and how you share information about the common patient that you're taking care of with your team members. So it really designing this well from the start is really imperative to that happening, and then having the technology that supports it happening easily is the second piece.
Yeah. And Amber, how can you add on to that answer by Christine there?
Yeah, and it's an interesting question, and actually I've not given that too much thought because it's one concern I have not heard in 8 months. I've not gotten comments from nurses saying, I feel like I'm disconnected from what the virtual nurse is doing. And I think to Christine's point, it's because we pretty much scripted admission and discharge. It's very clear of what our admission and discharge nurses are doing and how that process works. And again, it has to be standardized across your organization. If that nurse went to another hospital and floated, it have to be the exact same predictable experience. Often nurses are in the room. They're doing the other stuff that needs to be done while the virtual nurse is just asking questions and updating addresses, or, making sure that somebody's allergies are documented or whatever it is they're discussing in that intake. And the nurse is doing the other stuff, right? Setting up a pump or, doing other things that are happening. So there is a lot of transparency. They hear these conversations. They can give us feedback on what would also be helpful to be integrated into that virtual discussion. So we want to make sure that our nurses see it, that they give us feedback on it. So we actually do monthly surveys from our nurses to help us understand how this is being perceived, not just by our patients, but by the nurses themselves. And we track their satisfaction with it. We've made a commitment to say if this is not something that's helping you, then we're breaking one of our own core principles, right? This has to improve nurse well-being. Everything we do has to improve nurse well-being. And so if you come from that component and include your nurses, then you're going to avoid the stuff that creates a lot of frustration.
Can I break the rules and ask Amber a question? I'm so excited about what you just said.
Sure.
Can you highlight an example of ways that you've actually elevated nurses when it comes to your core principles? I love the idea that if this did not achieve enhancing your resilience, your experience, that we're going to table that. Do you have an example of how that really worked well? I think everybody can learn from that.
It's from the other direction. So as we are making decisions on what we want to implement next, we have certainly stopped certain things that we could implement because it didn't meet those criteria. So they have not reached the room because we didn't break our own core principles. We've not yet had it in reverse, where a nurse came to us and said, this didn't enhance my well-being, because we've only stuck to admissions and discharges. When a nurse gives us feedback that something seems difficult, for example, and I know that, we hear this everywhere, particularly as you're first starting up and you don't have a big pool of virtual nurses, is, well, I could have been done already. I could have just done that discharge and I had to wait 40 minutes for a virtual nurse to do it. So those are things that are kinks that work out with time. We don't backpedal on that. We just push through and build our team, and now we don't have as much of a wait anymore. But if we got feedback from a nurse that says, this is making my day worse, it's cumbersome, it's not helping our patient, then we would abandon it, because that's the commitment that we've made, and we would pivot and go do something different. This will not work if we don't collectively move towards a care model that makes more sense for our nurses and our patients. And that's the commitment.
Well done.
Great.
And our nurses know that. They need to know that we have the patients and the nurses' best interest at heart. This cannot be a reactive implementation for cost savings or for any other reason. Nothing we do in healthcare has ever been sustainable if we did it for that reason. And that also means that sometimes you need to make a financial investment in order to get to that ultimate goal.
Yeah, I hope that answered your question, Christine. That was great additional insight there by Amber. And then I think we have time for maybe one more question here. Someone asks, how do you best recommend providers integrate virtual nursing programs at their organizations? Christine, again, could you kick us off here?
Sure. I would start by saying that you have to become aligned at all levels on the problems that you're attempting to solve with this virtual or hybrid model. Making sure that you have clear goals in place, that they are measurable, that they are definable, that you have the systems in place to hopefully automate the measurements so that there isn't, FTE positions created to actually monitor the success. And, a lot of that can come in with time stamping in your EHRs and different things that can be automated. So I think the possibilities there are incredible. And then looking at the talent, who are you identifying to serve in those initial virtual nursing roles? The talent of those folks, their credibility in the organization, their ability to influence others, the trust others have in their practice and in their skill sets is so very important. So selecting the right folks to do that role, using your shared governance model or other mechanisms to make sure that everybody has input into the workflow discussions. And then as you decide how you're going to implement, I know I'm impressed at Amber's the approach that you did to do full hospitals one at a time. I think that takes a mature team to be able to do that. So I'm very impressed with that. If you're not quite there, I think having some ability to assess the readiness of both your leadership on given areas that you want to impact or implement care, as well as the stability of the staff. There are different mechanisms you can put in place and different tools you can use to assess readiness. I think that that's a key important piece to being able to set up first a unit and then an organization for success. And then finally, the communicate. I think those are essential pearls to success.
Great. And Amber, how do you best advise to integrate right now with virtual hybrid models?
Yeah, I think I'm going to go back to something I said earlier, and that is that this is new and there's not a best practice. We're all learning together. And if an organization says, hey, I think this is something that we want to go do for whatever reason, you need to get your own team aligned first, right? Your IT team needs to be on board. Your legal team needs to be on board. Your leaders have to be on board. Your capital allocation needs to be there for the equipment. And then my suggestion really is go look at other systems. Go see, right? We're happy to host someone at Sentara to come and look at how we do it, but go get ideas from other people and see what they are doing. On the flip side of that, I've made a strong commitment not to follow someone else's model. I believe it actually stifles innovation. Because if we go to our own nurses and say, what do you want this to do for you? You may come up with some really great ideas that other organization never thought of. So you're going to box yourself in if you adopt somebody else's model right now. It has to fit your culture, it has to fit your patient base, and it has to fit your organization. Christine, you said your team is mature. It is. We've been around since 1888. And as you know, nurses are great at change management, but you have to include your front line in this from the very beginning. This cannot be a top-down implementation. Your nurses have to be helping you lead this because they are the experts and need to be acknowledged as such.
Wonderful. Well, that's all the time we have for questions today. I want to thank our panelists once again for an excellent and spirited discussion. and our sponsor, Collette Health, for making this program possible. Finally, thank you to you and our audience for participating today and tuning in. We hope you'll join us in the future for another Health Leaders webinar. This concludes today's program.